So coming to the treatment options, so the classical standard of care, surgery is always the number one. Everybody, the moment you see cancer patients, let's cut it off, right? So surgery, but then we realize not everybody needs surgery. If you're lucky, you find a patient at an earlier stage, you can manage them medically, and now we have a lot of new treatment options. Now, not everybody needs surgery, but then again, it's up to the surgical guys to decide. So I'm not saying no to surgery. I'm saying do surgery only when it is absolutely necessary, right? So because surgery leads to further complications, and also it affects the quality of life of the patients. So typically it's a gastrectomy, right? If you're removing either part of the stomach or completely removing the whole stomach. If there is some blocks, you put a stent, all kinds of laser treatments. And now you have this robotic surgery is coming now, and then you have all these different procedures, gastrojejunostomy and those kind of procedures. Also, there's endoscopy. You can use now. Most of the surgeries are now being done in endoscopy. I know in AAG hospital they do like 10, 15 procedures almost every day. And then followed by surgery, chemotherapy, because when you cut the tissue, all the cells are leaking out. So you're basically creating an artificial environment of the circulating tumor cells getting into the blood. So you have to follow with chemotherapy. So these are the three main options, but you're not limited to this. The multiple. So depending on the individual experience, doctors may prefer one or other. So most common is either a platinum-based treatment or irinotecan. I've seen more and more people preferring platinum, which is safer. Irinotecan has a lot of adverse events, so it has to be administered under supervision. So a lot of it's a risky procedure. Many patients have allergy to irinotecan. That's the only challenge there. But it works. If it works, it works, right? So then we have radiation therapy and also a combination of chemotherapy and radiation. But where we are putting a lot of stress is on the targeted therapies and immunotherapies. This is where we need to create awareness because there's literally no toxicity in these newer treatments. So targeted therapies are the fourth umbrella, and immunotherapy is the fifth umbrella of treatments. So under targeted therapy, trastuzumab and ramucirumab, so HER2 targeting or VEGF targeting. VEGF only when we see either in the imaging or in the pathology, we see a lot of blood supply. So the cancer is angiogenic tumor. So then ramucirumab will really work in such scenarios. And now the newer one recently approved, ASCO 2022, there were some studies. They showed some really good results. ADCs, antibody drug conjugates. I think that's the future, I think. So instead of just giving chemo alone, putting the chemotherapy drug and the antibodies together, now you are not poisoning the entire well, you're only killing the mice or the rats in the well, right? So it's a very targeted approach, targeted chemotherapy approach. So ADCs are coming up in a big way. Also the traditional drugs, kinase inhibitors, like regorafenib. So in GIST, we do imatinib and a couple of other guys. So I used to work in Novartis when we were actually promoting imatinib, and then we are looking at different mutations which affect the drug. So nowadays, FDA puts that in the clinical pharmacology section, they'll also tell you the genetics. We have to do some companion diagnostics to see, will this drug work for my patient? So even in regular chemotherapy drugs, and especially in targeted therapies, it's not universally applicable. If you have like 10 patients, not all 10 of them will benefit from targeted therapies. You have to do the test and find out, will my patient benefit from this target? That's why the DNA testing is very important. Immunotherapy, as you know, it's basically the cancer is telling the immune system, I am still part of the body. I am not a bacteria or a virus. So it signals the immune system, do not eat me and do not kill me. That's the PD-1, PD-L1. So here you can see the ligand PD-L1 is on the tumor cell. The PD-1 is on the immune cells, the T cells. So once the TCR engages the neoantigens, that's a very interesting concept. Maybe you can have a separate session on that. How does the immune system recognize tumor? So like way back in 2008, when I went to MD Anderson for my postdoctoral fellowship, my boss, Dr. Satwanilapui, told me, immune system is going to take care of the cancer. I didn't believe him. Man, what is this? How can the immune system will take care of bacteria, virus, even fungi? It's not helping. Fungi is so big, right? We have so many fungal infections, immune system doing nothing. So many skin infections, nothing is happening. Parasites, immune system is useless. Cancer is so huge. How can an immune system kill the cancer, right? So I didn't believe in that, but the entire department was working on that. So that's when this whole PD-1, PD-L1 story started. and eventually became a drug called ipilimumab, CTLA-4, Dr. James Allison, my boss's boss's boss. So I come from the immuno-oncology group. So that time nobody thought immune system can take care of the cancer. We always thought surgery, chemo, you have to burn it, you have to destroy it with, you have to cut it out, you have to burn it, radiation, or you have to kill it with chemicals, right? So immunotherapy, zero toxicity. If you see in the movies and all this popular media, the moment you say cancer patient, they'll show a bald lady, right? Literally no hair, and then she'll be wearing a scarf. That's the typical representation of a cancer patient, right? But the people who go for immunotherapy, they don't lose hair, they don't have any kind of side effects, they don't have any effect on the alimentary canal, they don't have diarrhea, those kind of problems. They do have some other, sometimes they have neurological toxicity, they do have different kinds of adverse events, but you will not see the typical toxicities that you see in chemotherapy. So there's a separate set of guidelines for immunotherapy, immune-related adverse events, the separate set of guidelines. But clinical practice, I have spoken to many doctors, they're actually liking it. They're saying a time will come, we'll forget chemotherapy and radiation and surgery, and immunotherapy is going to be the mainstay of treatment. So that is the story. So basically, it's like a negative of a negative. So the cancer is putting a checkpoint, immune checkpoint, telling, don't kill me. Then you put the antibody and you block this communication between the tumor and the immune system. So basically, you are releasing the brakes and you're asking the immune system to go and fight, right? So that's why it's a checkpoint inhibitors. Inhibition of an inhibition becomes positive. So these are the most popular drugs, but there's another 30 drugs already FDA approved. Many are similar. There's a bunch of them anti-PD-1, bunch of them anti-PD-L1. Then you also have TIGIT, LAG3, BCMA, and so many other things coming up in the pipeline. So this class of immune checkpoint inhibitors is growing every day. Of course, Keytruda is the blockbuster drug. So they make around $20 billion every year. It's one of the biggest drug ever launched. And it's not just for one cancer, it's like multiple indications. That's why we have this totally new set of guidelines, tumor agnostic biomarkers and tumor agnostic therapies, right? So tumor agnostic biomarkers on the diagnostic side will help you to decide the tumor agnostic therapies, which treatment should be given to the patient. Just to wrap up, survival has improved. So you can see 1992 to 2020, so this is on the right side, the SEER data from US, and on the left side, you have the data, the 1 year, 5 year, and 10 year survival data from UK research. I think this is from 2017 or 2018, before COVID. So survival is around 17%, right? And 15 to 39, this younger age group, they are doing very well. And also in the last 40 years, the survival has almost tripled, right? 3x. All this happened because of this targeted therapies, and now the latest, the immunotherapies. So this is going to be a game changer. So gastric cancer is not a death sentence. It's just a chronic illness, just like diabetes or hypertension. It's manageable, treatable. If you find it early, you're improving the overall survival. That's the key. So this is actually looking very positive. So we'll see as this 2018 data. So once 2022 data comes, then you will know, it's actually even better now, actually.